So now we turn our gaze to Victoria, where the use of the Care Opinion platform has increased across rural and regional Victoria in the last few years. I have the pleasure of welcoming our next presenter, Dr. Andy Phillips, Executive Director for Patient Safety from Safer Care Victoria. Andy's presentation will focus on using lived experience in ensuring safety and quality of health services in Victoria. And Andy's role in Safer Care Victoria is to reduce preventative harm in healthcare. Andy has worked as a healthcare leader in 6 countries over 3 decades, including the Department of Prime Minister and Cabinet in New Zealand and UK National Health Service. Andy worked on the first National Health Plan for New Zealand and the New Zealand Charter of Values for the health system. He spent 8 years working to improve the quality of healthcare, particularly for Indigenous communities. Andy will share with us today how using voices of people with lived experience helps assure safety and quality in the Victorian health services. Welcome, Andy.
Thank you very much, Tina. If I can move to the first slide, maybe. And just to pay tribute to what Claire was saying about consumer leadership or leadership from people with lived experience, and also picking up Anne-Marie, the importance of kindness. We're actually running a co-design session on mindful kindness at the Gathering of Kindness on Sunday. Elisa, do we have my slides, or do I need to try and find them on my computer?
Sorry, Beck's sharing for me. So, because I'm letting people into the waiting room. Here they come. Thank you so much, Beck. Sorry, Andy, please proceed.
Oh, great. What a lovely photo. Thanks very much. So if I can move to the next one and just acknowledge country, I'm in Naarm, which is the land of the Wurundjeri people of the Woiwurrung language group of the Kulin Nation. I'd like to pay my respects to Aboriginal elders past, present and emerging. I'd like to acknowledge that this was and always will be Aboriginal land, and also, again, just to acknowledge that the outcome of the referendum a little while ago was not entirely positive for Aboriginal colleagues. So if I move on to the next one, and really just to talk about the fact that as we blend people with lived experience, people who have a clinical understanding, people have a management or governance understanding, this makes what we're doing a lot stronger. So drawing on our differences really makes us a lot stronger. I'll keep returning to thoughts about that. And if we just move on to the next one. So these are the 4 things that I'm charged with. I didn't quite get the introduction right. So my role is about preventable harm rather than preventative harm, but preventable harm. So I'm trying to do 4 things. The first thing is just try and use an understanding of where things have gone right, where we've got some great lived experience of where things have gone right. Try and make those things happen more frequently across the health system in Victoria. Second thing is where things have really gone wrong, use those patient feedback as gold for people to improve services so that things go wrong less frequently. And then the third thing I'm trying to do is where there are serious concerns about that things are likely to go wrong in the future, put actions in place to stop those things eventuating. And then the fourth thing is using lived experience to co-design services that are inherently safe and of high quality. So if you wouldn't mind moving on to the next one, that'd be helpful. So just some principles. I'll run through these very quickly. So the principles that I'm applying in doing this work, so recognizing that people with lived experience are hugely assets to the system, not a burden, not passive recipients, but really quite key to the not only the design but the delivery of service. And then using an appreciative inquiry approach, just building on people's existing capabilities and starting with what they have and looking for the opportunities to make those flourish. So sometimes we do things like needs analysis. I like to do a strengths analysis. What can a community do, or what can a consumer do? What can a consumer what can a consumer do themselves? What can the community do themselves, and build on those strengths? So we just move on to the next one. So mutual and reciprocity. It's a mutual and reciprocal relationship. It's interdependent, and people with lived experience are really critical to assuring safety and quality of services, particularly where they have some really strong peer support networks, working alongside professionals. So if we go on to the next one, that would be great. So blurring distinctions. you know, in the health system, we like to set up some distinctions, don't we? We like to have our uniforms, we like to have our language that people can understand, we like to have health services, it seems, that nobody can navigate easily. And I think we need to change that and challenge that and blur the distinction between professionals and people with lived experience. And I'll come back to this theme time and time again. The professionals enabling people, facilitating people with lived experience to take up leadership positions. I've had a number of really interesting conversations just this week in Victoria about things like we had a group trying to set up a steering group for people with lived experience, and we had all sorts of directors and executives and people like that, really important people. Who didn't we have on the committee? Well, we didn't have anybody with lived experience on the lived experience committee. And I had another consumer or person with lived experience working with us this week, really challenging some of the ways that we think about how we employ people. So, for example, in our position descriptions, we often have the requirement for people to have clinical qualifications, or we have the requirement for people to have management and leadership experience. And this person with lived experience really challenged us on that and said, well, where in your position descriptions are you requiring people to have lived experience? Because if you just have people who have clinical experience or management experience in these roles, they come from a particular perspective, and that's important. But where's the perspective of lived experience in roles? If we just move on to the next one, that'll be helpful. So I'm trying to work with three types of stakeholders, or three Ps. So people with lived experience, providers, and people who pay the bills, the people with governance experience. And really just using each of these perspectives all the time when doing this safety and quality work or co-designing services, really quite important. We'll move on to the next one. So this is a framework that I designed over about 20 years of how I work in co-design and co-creation. And I've used this at the level of an individual patient-clinician interaction, and also for designing large-scale health systems, such as the health system in New Zealand. So there are some very specific parts of it. The first one is how you prepare people with lived experience, how you make sure that they come into the conversation or the work with the same type of knowledge that people who are professionals or who are payers. How do you make sure that we bring people on an equal footing? So there's a preparation phase. The second thing is we really want to know what the agenda of people with lived experience is. What is it they're trying to achieve? How is it they're trying to live their lives? And that's really the key thing that we often miss in these conversations. What is the agenda that people with lived experience are bringing to this conversation or discussion or piece of work? And then quite often there's a need to, when we've got people together and we've found out each other's agendas, quite often sometimes a need to get some more information. And then when we have that information, we're fully informed, we can come and discuss options. And in a patient-clinician interaction, we might have something like an options grid. If we're doing large-scale system design, we might have had some information from a large survey or other form of understanding lived experience, which give us a lot of information about how to inform choices. Of course, then we need to agree the way forward. Then we need to make the change. We need to review the outcomes. But all of this is always informed by improvement or innovation and audit to make sure that we're actually getting the impacts that we thought about. Very often in the quality and safety work that's been done for many years, this aspect of impact assessment has really been left out. So you do some recommendations, you do some actions. People very infrequently look at the impact of the work that's happened. Let's just move on to what I think is probably the last slide, or maybe one of them. So this is the sort of ways in which we've used this approach in Victoria. So this is where we've put our money where our mouth is. So we've had some parents who've had extremely tragic experiences where they've lost their children. Their children have unfortunately come to preventable harm, or they've unfortunately died as a result of some things that have happened in the health system. We have this program that we're calling Safer Care for Kids, and it's the parents with lived experience who are designing that program. They're not just involved or consulted, they're actually designing that program. So we have somebody who has a background of having a child who's very unfortunately been harmed by the health system. That person is paid to lead the program. And then we have a whole group of parents who are coming together as a group to provide the design principles. So they'll be designing the program, and then it will be up to us to, apologies, then it'll be up to us to put that into place. So it's really people with lived experience designing the programs that people like me, professionals, are then required to put into place. Another thing that we're doing is we're using people with lived experience to lead the most important and serious reviews of the systems. So in Victoria, we have this system of autonomous governance where each individual provider, we have 76 of them in the public system, they have their own autonomous governance system. We don't have central control, we have autonomous governance. And from time to time, we need to go into those organizations to take a very serious review of how they've been delivering their services. And what I'm trying to do now is make sure these, for the most part, are led by people with lived experience. They're the team leaders, they convene the team, they do the management of the team. Maybe I could talk a bit about the safety and quality minimum data set. One of the ways in which I'm trying to assure the quality and safety of services across the system is to set out a set of data. We have 36 different data items in 6 domains, using the Institute of Medicine and 6 domains of quality. So safety, timeliness, equity, effectiveness, person-centeredness, and productivity. And these data items have very much been co-designed by people with lived experience, and they have lived experience into the domain. So one of the domains is if there's been a serious concern expressed by people with lived experience, that's a really interesting flag for us then to go in and look at the system. Looking at patient stories, so very often we're now using patient stories to influence design of treatment pathways. And when those experiences are from Aboriginal and Torres Strait Islander people, or they're for people with culturally and linguistically diverse backgrounds, then we know that we need to design services in a different way. As Tina introduced, I'd done a lot of work with Maori and designing Kaupapa Maori patient pathways in New Zealand, and now just trying to work with Aboriginal people and people with culturally and linguistically diverse backgrounds to see the world from their perspective. I had a conversation today about this, about how we look at cultural safety. So this is a talk about safety. My strapline is there's no safety without cultural safety. And I could come at this from a Western medical paradigm and say, well, what I need to get a reporting system about cultural safety issues, and I'll build it into my systems. But my experience with Indigenous people says that that's not often the way that Indigenous people deal with these types of issues. So I do want to work with people from those backgrounds so they can design the system rather than commenting on the system that I've designed. We're very much using the information we get from care opinion and other types of feedback mechanisms to provide some learning for services along the lines of those 4 things I talked about earlier. And then the last thing I'd say is we now have very important consumer input into multi-agency reviews. Healthcare is often very complex, and unfortunately patients come to preventable harm if they interact with that complexity. So I think what I'd say in summary is I very much agree with the comment from Anne-Marie about kindness. I think it's about mindful kindness, and I hope some colleagues will come and help me co-design that mindful kindness or kindfulness at the gathering of kindness. And it's about moving people with lived experience into leadership positions so that they can lead us, they can take their leadership part alongside us, and not just in honorary type positions, but actually in paid leadership positions where their skills are as valued as people with governance or clinical skills. Thank you very much, Tina.
Thanks so much, Andy. And the care opinion team will also be at the Gathering of Kindness event in Victoria, as we have been in the past couple of years. Really a wonderful network and group of keen leaders looking at this movement across the nation. So very keen to be able to join that space. Thank you for your presentation, and your wealth of experience and leadership is vital for the broader implementation and uptake of care opinion across Victoria, Andy, and amplifying the consumer voice and improving quality and safety across your state.